patients. And like a lot of patients will fight tooth and nail for me to be there at their birth. So it's one of those things, either you have it or you don't have it. And what I really do is that when I meet patients, I try to understand them, understand their motivation, understand and be honest with them and build a relationship. It's about the relationship that you were discussing, and I think that's what's so important, because you trust people that you have a relationship with me. And that's one of the things I do teach my residents is like, and I'll tell my patients, if you don't like me, that is A-okay with me. I want you to find a provider that you have a relationship with, because that's where you and the physician or your provider are going to get the best out of your relationship, because you're going to be honest with me and I can be honest with you, and we can help each other achieve what we set out to do with this, which is a healthy baby and a healthy mom. And so for me, I am very honest about those things, and it doesn't hurt my feelings, because I know I'm not everybody's cup of tea, and that is okay. But I want everyone to be able to build those relationships. And I know we talk about I think we do have one thing that we have to do in the midst of this crisis, this maternal mortality and morbidity crisis, is that we have to support each other as providers, as birth workers. And I think that is one of the biggest things that really hurts my soul, is because sometimes I see midwives, doulas, and physicians go back and forth with each other, and it really bothers me, because we are all there with the same goal, and we have to all figure out where we fit and where we play in that role. At Howard, we do have midwives that work on the floor 3 or 4 days a week. They usually bring their patients in at that time, and then patients will bring in their doulas, and they are allowed to go into the room and be part of the team. I know during the pandemic it may have been a little different, but now doulas are allowed to be back in the room. And I think having that support system and everyone there is a wonderful thing. Like, I let a midwife, they're like, hey, the baby's breech. Do you want to do an ECV? She was like, okay, while you wait and go deliver that baby, I'm going to try to do my midwife thing and see if I can spin the baby before you get back. I was like, go ahead, do that. And if you don't spin the baby, then I'll come in and do the ECV. It's like a tag team. And that's what I want to see more in the community, is for us to like work together to help support these birthing peoples so that they can have the best outcome for them. And whatever a midwife can't do, I'm there to help out. You want a vaginal delivery, by all means. Somebody needs a C-section, I'll take them to the back, because I can do that. You know what I mean? And it's great. I just had a family medicine physician who works in the community. She brings her patients in. She can't do a C-section. Her patient was very sick. I let her go in. I let her go back with her patient because her patient wanted her there. I did the C-section. She came out and she was there during the entire time. So I think we have to start working together and supporting each other during this maternal morbidity and mortality crisis, so that we can help reduce some of this.
I'm going to just interfere just a second, because I know that you have some babies waiting on you.
Yeah, I do.
But I want to just have some questions before she leaves, and we won't feel she's going to leave any minute. So I guess we have about 10-15 minutes. So let's get your questions in now, because I'm sure you have a zillion of them. If not, that I have. Yes, sir? Okay. Oh, okay, go ahead.
I don't really know. I think Hi, thank you so much for what you do. I just wanted to, you said birthing people. I just would like to know if that is a directive from the higher ups. Are you changing your language in order to be more inclusive? Because, that's part of the whole birthing process as we move into the future.
So I do try to be as inclusive as possible when delivering my patients, because I do have patients who don't identify when they come in as female or male or whatever, and they would prefer they. And we make sure that we put that in their paperwork, that they prefer they, and that we are going to respect that. Because for me, my concern is not what your pronouns are at the end of the day. my concern is your health and your baby's health. So if that is what you prefer, then that is what I will do. And that is what I have done. It's not really for higher ups. We try to respect cultural difference as well as personal differences when patients come in. We have some women who are Muslim and they only want female providers so that they can take off their hijabs, and we try our best to accommodate those wishes. We have some women who have had traumatic experiences in their lives and they don't prefer male providers, or they want things done a certain way. I had one woman and her partner come in. They were a same-sex couple. They wanted music. They wanted to turn down the lights. I said, it's all fine as long as I can do what I need to do and there's no emergencies. I don't really care as long as it doesn't interfere with the care that I need to provide to make sure that you and baby are safe. So yes, I try to be inclusive and respect my patients. I don't really separate that because I think it's part of who they are. And if I have women and they want to be called women or whatever their name is, I respect that too.
Thank you so much. I'm really enjoying this conversation. I was actually speaking to my midwife, Marcia Jackson, earlier today, and she wanted to be here, but she's catching a baby. I spoke to Ms. Holmes when she first got here, and I was referencing Listen to Me Good, and you talked in the book about interviewing over 60 Black granny midwives in Alabama, and I thought those archives were in Alabama, but you said, can you speak about those archives? Sure. And then also I would love to hear the preservation of birthing traditions here in the DC, Maryland, Virginia area. Now that, Marcia Jackson, one of the legends, is retiring, and thinking about all of that matrilineal memory and how we're going to preserve that going forward.
So I'm going to be brief in my response because I want to make sure that you have a chance to answer the second part of the question. I interviewed 50 traditional midwives in Alabama back in 1981, and all of those audio tapes are on deposit at Smith College as part of the Black Women's Health Project, and other archives related to the Black Women's Health Project are there. They will be accessible, I think, sometimes towards the end of this year, but there are transcripts, and I think that it's important to open it up. One of the issues that has slowed us down a little bit has been the issue of informed consent in terms of opening up opening up the transcripts, and I think it's important to honor the families. So we're trying to reach out to all the families to make sure that we have full consent, because we know about those abuses that have occurred in the past where people come in and they record someone's voice and then the family doesn't know about it until some other time. But I want to make sure that you get a chance to respond to the second part of the question.
Yeah, I think we are now moving back to more traditional birthing positions and birthing experiences in the obstetrics community. I think now moving forward we have identified and we know some of the mistreatment and misuses of the Black body, and I think with the Anarcha movement and the Betsy movement, where they've identified how there were slaves that were really mistreated and utilized in the development of the field of obstetrics and gynecology, people have really started to look more into basically how Black culture in and of itself has contributed to the birth of this nation. Unfortunately, I hate to use that term, but I think books such as Ms. Linda Holmes' book is actually one of the ways that we can actually preserve some of those traditions, and I'm so glad that she has done a lot of this research in literature. And I think now including and welcoming midwives into the birthing process has also helped as well. You may not be a big medical person that reads journals, but they did a research study on the birthing balls and the birthing peanut balls that people use during their birthing process, and they they actually found that the birthing balls, the ones that people like to bounce on, was shown to decrease pain experience during the first stage of labor, and that the peanut ball that people have does decrease the amount of time in the first stage of labor. So they are starting to explore more options and incorporate those into the medical field, because we do know that they can help. I mean, although people may not utilize them all the time, we actually have the balls, we have the peanuts, we have the birthing bars at Howard. You just have to ask for them. We have all of those things, the handles, and I have caught a baby on hands and knees. As long as you have an epidural and I can catch that baby, we can do that too. Like, I am all for it. I think, COVID may have hindered some of our progress in this space because we had to be restricted to the rooms and masks and all of that now. But I think now going back to like walking and everything while you're in labor, I think the field of obstetrics and gynecology is really moving back to some of the basics of childbirth. So I think we're headed in the right direction.
Yeah, because I think that the thing to understand is these are the ways of traditional midwives in the United States and on the continent since the beginning of time. Alternative birthing positions, not lying flat on your back to give birth, but using the stooping position, right? Massage. Those women, there have been studies done, their ability to prevent cesarean sections by being able to rotate the baby in uterus, right? And the disturbing thing to me is it's called How Do We Know What We Know? So for the medical world, we don't know it until some white men come together, right, and do a scientific study in the Western model, right, and then it becomes acceptable or usable. Whereas when the midwives in Alabama tell me, or the midwives in Ethiopia tell me, we've been doing this since the beginning of time, we know how to do this since the beginning of time, and the testimonies are, like they said in Alabama, we got here because of midwives, right? And even the studies, there's one wonderful study that was done by the Center for Disease Control in North Carolina back in the 80s or sometime, but they found that midwives who had traditional granny midwives outcomes compared to the outcomes of doctors trained in medical school when they had equity in terms of access to prenatal care, that actually these black women had slightly better outcomes than the doctors, right? And those are the studies that they don't want us to know about. But we also have to accept those truths when they come from us. That we have to say, when we hear this truth tonight, when we hear this, when we see the stories like we were talking about from the Alabama women, and the stories in this book that are not being presented in the medical model, but as stories, truth, that is a model that we can accept and adopt as a way of knowing with confidence. But I do want to ask you about nurse midwife programs at Howard, because Howard did have a nurse midwife program at one time. Do you think there's any hope for that?
We do not, let me be very frank, we currently do not have a nursing midwife program at Howard. We don't have a doula program at Howard, but I think one of my first goals would actually be to actually start, if I can have the time,
and the
support of the community and money and dollars, because it takes money. Let's not forget about that, to train people, is to actually have a doula program or a midwife program at Howard. I think it would be remarkable and complement what we do. And I tell people all the time, don't let things fool you. I know, we at Howard have a different perspective with the maternal morbidity and mortality. I can tell you, because we have people who sit on the board at Howard, in the city, who does the review for the maternal morbidity and mortality. I've been at Howard for 2 years, and I have not seen one death of a mother. Now, babies, they do come in for different various reasons. Sometimes they are fetal demises before they arrive, but I think it's not as many in the city, in the city of DC. We don't have as high of a mortality rate, morbidity rate, I will say is very, very high just because of the population. And one of the things in my last plug, because this is going to come from my nutrition background, is that I think as a culture, we have to take better care of ourselves going into pregnancy, because a lot of things that we expect are the outcomes we expect are the outcomes they have from healthy women. I can't tell you right now how many people I see that are 23, 24 with chronic hypertension and diabetes going into pregnancy. So you are already putting yourself at risk on the other side, because pregnancy is beautiful, but it is a change in the physiology of your body, and you have to respect that. At the same time, we have to respect our bodies, I think, a lot better going into that portion of pregnancy, because we are birthing a baby. We are nurturing babies. And I will give another plug, is that we are now learning more in science that the in utero environment plays such an essential role of health and disease after birth. So what the baby is exposed to in utero affects how the baby's health on the outside. I can tell you probably in the next 20 years we're going to know a lot more about that than what we do now. And so that goes back to the beginning of we must be healthy first before we go into pregnancy. So you can't come in with diabetes uncontrolled or hypertension and expect to have a glorious birth out in the wild and possibly not, and have minimal risk. There risk, and I hope that you do have a wonderful birth that has low intervention for everyone, but if you can't come in with that expectation. And I think that is one of the biggest things that I would like to say, because I know, because I have my master's in clinical nutrition, that what you put in your body is essential to how you feel and how you become and who you become. And I was very intentional about what I put in my body when I was pregnant, even before, because I knew I would be having a child later in life. So I wanted to be in tip-top shape because I already knew I had a couple of things not working in my corner at that time. So yes, I think obstetrics now is definitely moving to more traditional things, but I think also as a culture we have to take it in the responsibility of caring for ourselves before and after, and that means as a culture, because both of my parents are deceased, and I will tell you, having a child on your own without having the support of your family has been one of the hardest things that I can do. So I empathize with a lot of my mothers who have to go to work, 4 and 6 months, weeks after they give birth, and not having the support of someone there to nurture your child in a trusting way, and having to put your child in daycare. I was horrified because I had my son in November of 2019, and the pandemic hit in March of 2020, and I had to go back to work. And I was like, I don't want to put him in daycare. Do I go back to work? It was a big decision. So I couldn't imagine what women, who do this have to think about on a regular basis. And that goes back to that community of women that you need to have before the pregnancy that are going to support you after the pregnancy. And I didn't have that, and I know there's moms out there with 3 or 4 children that probably feel the same way, and it is overwhelming and it is hard to do. So I just want to encourage everyone to enjoy this book, because it is amazing, and I think it has a lot of traditions in it that we need to get back to, and support a birthing person if you see them.
Yes, thank you so much. I just want to say, it was so hard for Rashonda to negotiate, because you see where her priority is. But I just want to thank you again for taking the time, and also just for reminding me and everyone here that we have to be responsible for ourselves. I mean, if we don't know anything else about living in the United States, if we wait for the white medical system, we wait for doctors, and we are going to have to take the responsibility, and I think your last comments are so relevant. And that's what Black midwives did, right?
Yeah.
They said, we're going to take responsibility for our health and well-being.
In our community.
In our community.
In our community, because at the end of the day, it's our community.
Thank you so much. Thank you, thank you.
Thank you so much for coming over. So wonderful to know that you are our neighbor, that you're here with us, that you're a wonderful young lady, and we just appreciate what you bring to our community. And thanks for bringing Howard and giving us another perspective about Howard, because we don't always hear that much. You know, what we hear about Howard is not always great.
Oh, there, wait, I know.
So we want you to shape up the place.
Yes, that's what I'm working on. It's a process.
Okay, and are you running now? Or are you going to stay with us a little bit longer?
It's 8 o'clock. I probably got 5 more minutes.
So,
and then,
okay,
yeah,
so
I
you
have
have
5 more
time for
minutes. Yeah, because I
okay.
left a little late. Yeah.
Okay. Bravo. Who gets the next? Okay.
Hi, thank you. My name is Mick and I actually live in Baltimore, but I'm a community doula and lactation specialist, all the things. Also an anthropologist, ethnographer. So, and I'm Ethiopian. I did my research in Ethiopia with Ethiopian women. I cannot wait to read your book. I'm going to cry through the whole thing. I'm planning on starting midwifery school next year. I'm going the CPM route, and I would just love to hear your thoughts about the lack of birth centers. As a doula, I did my first birth center birth, and I was like, why do we go to hospitals? Like, I don't, it was beautiful being a Black midwife, a Black birthing person, and everything. And so, what do you think are some of the barriers to starting and having more birthing centers in this area?